speaking of risk-adapted approaches, we're seeing some of these trials in bladder cancer with ctDNA. What are your thoughts on ctDNA when it comes to kidney cancer?
Right now, I mean, it has not translated to a clinic. I mean, we know from kidney cancer that it's a tumor that does not shed a lot, so there's not much utility in that sense. So personally, I never look at it in clinic. Also, same thing with information from next generation sequencing. I think it's informative and it gives us like some new things to know, but at the end of the day, it does not change my approach to patients. I don't know how are you approaching this?
Yeah, similarly for me, I do a lot of this testing mostly to see if we can identify some patients who in a later line therapy may benefit from a specific clinical trial, but in terms of FDA approved or regulatory body approved patient management, it doesn't really impact our ability to take care of patients today. And I think largely in part because of the sensitivity issue with at least the current technology of ctDNA approaches in clear cell kidney cancer, it's not that particularly high.
Yeah, as of now, but I like to think that maybe in the future with, like either deeper or more advanced technologies, we may be able to revert that.
Yeah, and certainly there is some, indication that with, changes in the technology, it's going to be very useful. Even if you look at like a small change with, like what Signatera has done, where instead of taking like an off-the-shelf ctDNA-based approach, they're doing like a bespoke approach based on the small, data that's been presented with Signatera-based approaches. It still isn't, dramatically more sensitive, but it is more sensitive. So what that is really demonstrating to me is that we can make some modifications with the technology to make it more applicable for this population of patients.
Oh, absolutely. And is anyone else checking next generation sequencing up in kidney cancer? Not yet. Okay. And so we have a lot of exciting data on Saturday, including COSMIC-313, which you'll be presenting. So why don't we just start with maybe some updates when it comes to COSMIC-313?
Yeah, sure, with pleasure. So the COSMIC-313 trial is the first triplet trial that has been conducted, first phase 3, which randomized patients to receive cabozantinib plus nivolumab plus ipilimumab, so a triplet, versus nivolumab plus ipilimumab plus placebo. I'm going to refer as a doublet. And it is a very important study because for the first time we had this comparator that was already a doublet, one of our standard of care. Initial report was at the 15 months follow-up demonstrated the benefit in progression-free survival. And so what we are reporting now is the final analysis, 45 months follow-up. So we still see the benefit in progression-free survival. Hazard ratio is 0.81. And we moved from median PFS of 11 months with Nivo-EP to 16.6 with the triplets, so PFS benefit. But with regard to overall survival, there is no difference between the two treatment arms. And I think this study is very important because it really paved the way for triplets. We also identified that managing toxicity in a blinded study is not easy because you had to dose reduce your cabo/placebo pills, as well as withhold, for instance, the ipilimumab. Mm-hmm. And so if you pay attention to the drug exposure that you had in this triplet trial, the median daily dose of cabozantinib is only 22 milligrams per day. So it's clearly that patients were low exposed to cabozantinib, but also the ipilimumab use was reduced in the triplet. Only 58% of patients actually received the 4 cycles of ipilimumab versus 75 in the doublet. So it shows you that triplet is not easy with regard to toxicity. Half of the patients in the triplet arm had to discontinue at least one drug of the triplet regimen, so it's a lot. And the toxicity is mostly driven by the combination. You had liver enzymes elevation, for instance. But really, it is important to say, if we're moving toward triplets, how do we manage toxicity? And so the second part that is interesting is that we report on the biomarker piece of the trial, which use the RNA-seq data for 2 different analyses. One of them is actually connecting to your questions around biomarker, is looking at the molecular clusters that were developed in the Emotion 150 and 151 studies. And here the 7 molecular clusters are not associated with a differential benefit with regard to cabo-nivo-EP triplet. The second part, still using RNA-seq, is to do what we call immune deconvolution. So you're looking at the relative abundance of the different immune cells. And here again, you correlate with the outcome, overall survival and progression-free survival. And interestingly, what stands out is that there is a population, M2-like macrophages, that are associated with the outcome. And we know that this cell population is usually associated with immune suppressive activity, usually IMDC poor feature in our data set, visceral mets, dismal prognosis. And here, adding cabozantinib in the patient that were high with regard to this immune modulatory cell population is actually reverting the detrimental effect of the M2-like macrophage immune suppressive role. So this is only food for thought. It's going to require further validation, but it's a bit in line with your myeloid signatures back in the BEV trials plus atezo.
They weren't my signatures, but
We're going to say it's yours, okay?